Well, it's a pleasure to be here again. Thanks again to all of you who are joining us for, I guess this is the third or fourth that people have attended. Today we're going to be going over sort of some of the nuts and bolts of actually doing the procedures.
Procedure for diagnostic really starts in the OR, and this is showing our proprietary, Monteris' proprietary head fixation device. And it's a bit like a stereotactic head frame in the way it's assembled. There's a optional front piece of the ring if you need to pin anteriorly. I would say most people who are using this use just the back side of the head fixation. If you need posterior approach for an entry point at the back of the head, it does allow you some flexibility to be able to turn the head fixation ring, and that's all integrated into a patient transfer board, which we'll use to move the patient to MRI. And once a stereotactically placed bolt is back, allows the trajectory to be maintained for the probe. And once that's in place, then we move that whole patient transfer board with the head fixed over to the MRI scanner. And then we'll put the patient on the MRI couch, and we'll move them to the back side of the MRI scanner where we put the laser probe in, as well as attaching the probe driving apparatus. And here you can see everything assembled, ready to start the ablation. From there, we go ahead and get a volumetric scan to show where the probe actually landed. We use the robotic apparatus to drive the linear position of the laser probe, as well as changing the rotary direction of our side fire laser probe. And here you can kind of see an animation of what that looks like at the back side of the scanner and as it's turning within the target volume. As the surgeon is doing the procedure, they're controlling all of these movements directly from the software interface within that workstation. And this is the view that the surgeon gets as they're doing the ablation and redirecting the side fire laser probe to cover the entire volume of the target area. So that's just a quick snapshot of our diagnostic workflow.
You know, diagnostic scanners are quite common as far as moving patients over after the bolt is placed into the diagnostic scanner. If you're lucky enough to have an intra-op MRI, that's crucial. I think it does help. Obviously, from a sterility perspective, you're in the OR already. You can simply roll out the MRI once you're all set. So the key difference here is that there's things that we do. Everything that we would do, we do an order in the OR before we roll the MRI out. As opposed to kind of moving to the MRI, the diagnostic MRI scanner, and then doing things like affixing the probe driver, putting the laser into down the bolt, etc. So all that obviously gets done in the OR here. So once if you think about all of you, no matter whether you have experience with LIT or not, have done a stereotactic biopsy at some point in your training, whether you've used VariGuide or any of the other competitors' equipment. The fact is, you know how to do that, and essentially it's the same workflow, except that in addition to just kind of dropping a biopsy needle down that trajectory, what you're going to do is you're going to screw a bolt in place, and then you're going to put the laser down that bolt, which serves as a means of fixing your trajectory. That laser will go to a depth that you pre-prescribe with the Monteris folks, and then after that, you put your driver on, and once that driver is affixed, that's when you are going to go ahead and roll the MRI out. So the big difference is, where do you stop the workflow? If you're doing a diagnostic scan, you're going to do the surgical trajectory finding in the OR, and then you'll put the bolt in place down the same trajectory. After that bolt is placed for a diagnostic scan, you're going to roll over to MRI, and that's when you're going to put the laser probe in place, affix the driver, and then roll the patient into the scanner rather than the scanner over the patient.
Yeah, I just want to point out that, if you look at these two workflows as they were before, the only real difference is that steps 5 and 6 are flipped for the diagnostic scanner versus the intraoperative MRI. That's not necessary, and you can, if you wish, place the laser in the OR suite and then still roll with the laser inserted down to MRI. That's how I've typically done it, simply to avoid a lot of manipulation in the MRI. It varies, I think, from center to center, depending on what kind of MRI area you have, whether you have a treatment room that is adjacent, whether it is easy to do procedures there. But you really can do it either way. The other change that I've marked here is putting this X over that's really supposed to X out the head pinning, not the prepping and draping. We do prepping and draping routinely. But head pinning, I think in this case is somewhat optional. You know, we have, I think the Atomo board is great. It is certainly nice to have that sort of fixation, and it does create the most stable images. It is limiting, and the reason that I stopped doing it is because in many of the in the rooms where we use this, we have a 60 centimeter MRI bore, and it becomes relatively tight if you have the head ring and the thickness of the Atomo board. I think the Atomo board is beautifully designed, but it really needs the 70 centimeter bore. So in many patients, I do not use it, although I do sometimes.
So planning stages for tumor. So right now we're dividing this process into steps, of course. And the first part is all the things that you're going to do preoperatively. And in the tumor case, it's going to be different, of course, than it would be in the case of epilepsy, which Dr. Neimat will talk to you all about. But I divided this into kind of essentially 3 divisions. So first is pre-op imaging. Of course, you're going to need an MRI. This stuff is really self-explanatory to all of you folks. You want a thin cut MRI that you can navigate off of. One thing that sometimes people make mistakes about is if this is going to be a low-grade tumor. So if you see the scan here on the right, this is a small right thalamic glioma that I did in a 13-year-old. You can see it's very small. It's about 1 centimeter or less. You know, this is the kind of thing that having a thin cut off of a contrasted image is probably not of much use to you. So make sure that you ask for your thin cut off of your T2 or your flare or whatever it is you prefer to look at in a low-grade glioma protocol. People make that mistake all the time, and then all of a sudden they're having to get an intraop MRI to do their navigation, and that's just a waste of your own time. Other things I would just throw in there, depending on what you're used to getting, you know, DTI, functional MRI, those are all things that can actually be incorporated into the Monteris software. You load them into BrainLab or whatever it is you use for navigation. Through DICOM, you get kind of a black and white version of that gets put into Monteris's imaging, and then that can become an object that you can see. So you can actually watch yourself burn up to either white matter tracks or functional objects that you've identified, whether it's hands, sentences, whatever it is. So if you want to incorporate that data into your burn, you absolutely can. And so it's worthwhile saying that whatever you would get for an open surgery, it's worthwhile getting that for a lit surgery as well. Trajectory planning. So this is just like you would do for a stereotactic biopsy with a couple of little caveats. So, you know, standard stuff. You're going to try to avoid the sulcus if you're dropping a needle and or a laser catheter down into the brain. So you want to try to watch that, you know, you can see that when you do the review scan or the review page, you can watch yourself go down through the brain, try to avoid a sulcus. One thing that you can do, for those of you that use BrainLab, I'm sorry that I'm not as familiar with the stealth technology here, but if you use BrainLab, there's the kind of positioning and then there's the review, and then there's a middle tab there. And on that middle tab, you can actually do some things to your trajectory. So for instance, you can add a diameter over it. And if you look to the right on this image here, you can actually see that there's a cylinder that we've incorporated into the image here. I'm not sure if you can see my arrow. That cylinder you can set to a particular diameter. Here we've set it to 30 millimeters. So as you're kind of scrolling down through the brain from your entry point to your target, you can actually watch that cylinder go down over the object that you're going to lesion, and you can see whether or not it appears that it's kind of inside that 3 centimeter cylinder. That gives you a sense about whether your trajectory is optimizing your coverage for the lesion. So that's just something to think about as well. It's a really nice trick that you can do. I think it's under the Properties tab in BrainLab, and it's really helpful. DTI, I think very useful. I essentially get DTI on all of my patients now, regardless of what the surgical options are going to be. It allows you to, obviously, with the newer BrainLab software, with Synaptive, with whatever your navigation system is, to essentially create objects, corticospinal tracts, optic radiations, arcuate fasciculus, and then essentially identify those by function on your scan. And that allows you to essentially avoid those white matter tracts as you drop your biopsy needle and your laser down. And then, of course, as you do your burn, to make sure that you're not approaching those areas, you wouldn't want to bring anything beyond yellow line into a white matter tract, for instance. If you're bringing blue line into that, you should expect a deficit. Rule of V's. This is what I call the rule of ventricles and vessels. So these things are things, if you've seen me talk about this before, they contain water or fluid. Water in particular has a high specific heat. It's going to carry heat away from where you want to burn. So if your lesion is up against a ventricle or the ependema, or if it's right up against a large vessel, you may find it difficult to burn right up against the wall of that. So you may be leaving 1 or 2% of your lesion behind. Just be aware of that. And then the biggest thing that we sometimes suffer if we're doing shallow lesions with the lit is this this artifact that comes from the bolt when you're in the MRI scanner that makes it difficult to see just beneath the bolt where your heat is going. And so you're looking to see heat expand beyond that artifact, and hopefully your lesion is beyond that artifact so you can see the heat go out to the borders. But you want to be careful of that. So it's an issue for superficial lesions where the bolt interferes with what you can see with the MRI. One of the things, there are a variety of tools to avoid that issue. And I know that Dr. Neimat's going to talk to you about StarFix later and a couple of those things. But beyond that, if you simply are just kind of used to doing the same workflow every time, which is bolt placement, laser down the bolt, roll the MRI out, heat your lesion, that bolt can be placed more shallow within the skull. So normally it's 16 half turns or 8 full turns. Sometimes we'll sit it proud a little bit more in the skull as long as we know we have good fixation. So that might be only 8 half turns. And it does help with the artifact that the bolt creates a little bit. And it does allow us to treat superficial lesions a little bit better. And then the last thing as you're planning your burn is what type of laser are you going to use. There's 2 options, at least with the Monteris system. One is the full fire, which you see pictured on the right here, which is essentially heat emanation in 360 degrees. The other is the side fire, where the heat is being pushed out in one direction. I will tell you, I've done well over 100 cases at this point. I exclusively use the side fire, and that's because I do tumors and because my trajectory may not be right down the center of them. I want that capacity, that fail-safe of being able to push the heat out more in one direction if I need to make sure that I avoid eloquent areas that might be at one border of the lesion and push heat out further towards the non-eloquent areas and make sure I cover the whole thing. So, tumors are not often completely spherically shaped, and you may not be right down the pipe on them with your trajectory. So I think the side fire, although slightly slower in the burn, is the safest option for tumor surgeons.
Yes, I mean, so I think really stereotaxis is pretty similar for both. With epilepsy, you have the advantage that for the most part, we are planning a single trajectory. The most common trajectory is going to be this hippocampal trajectory that you see here, and so there are maybe some particulars that allow you to do that. The first, it is a relatively long trajectory, so I typically am using a firmly fixed method of stereotaxis, like a StarFix frame. You can also do it, I think, with a Lexel or CRW. It potentially could be done with a sort of Vario guide, a more flexible sort of form of stereotaxis. I have avoided that. I think it's important to be very specific. The real trick, I think, with this trajectory is that you're coming from the occiput, and it's best if you can come, if you see, let's see if my mouse will show up here. If you can see on this sort of semi-sagittal view, you want to come up underneath it. You don't want to come from high in the occiput and sort of cross the ventricle. You prefer, if you can, to sort of start relatively low, come up, low in the temporal lobe through the parahippocampal gyrus and into the hippocampus itself. That avoids the small possibility of actually having your laser find its way into the ventricle and be sitting in the ventricle, which is something we've managed to avoid with this strategy. As far as the ablation, people talk about, even with surgery, before we were doing ablation, people talked about getting a very extended resection from the amygdala all the way back to the tectal plate. I think that has value, but this recent study by Chen Wu, which some of you may be familiar with, really demonstrated that what seems to be most effective is ablation in the anterior hippocampus, entorhinal cortex and amygdala. And so really since that demonstration, which was a combined study with 11 centers, including ours and Vanderbilt and obviously Jefferson, that really seems to be that's the important part of this. And so I do try to get the posterior hippocampus if I can, but if there's a very curved hippocampus, I will emphasize the anterior part.
Yeah, so I think, it's like anything. It's really helpful to have similar teams that are working with you for these procedures over and over. You may not have that luxury, of course, and particularly in an academic center, it might be a CRNA or a resident that you've not seen before, and so you want to make sure that you communicate up front with what you need, and that's true for any surgery. That's not specific to lit, of course. So make sure you talk to your anesthesia team, let them know what you're going to be doing. I think the big things here are we actually like the bear hugger in these cases because it's going to warm the patient to a point where it starts them at a higher temperature, and that actually allows you to get to your cooking temperatures faster. So it'll speed up your case if your baseline temperatures are actually a little bit higher. So is it crucial? No, but it's helpful. You want your anesthesia folks to have a temperature probe because it's a good backup to the temperature probe on the laser, and that's going to allow you to set your reference temperatures that you can use to essentially calculate. When you think about it, I don't know how much you guys know about the physics of this, but the phase change data from the MRI is not actually calculating a temperature. It's calculating a delta temperature from the reference points that you set as you go around, and now the software does it, picks these points around the periphery of your field. So those reference points, you really need them to be accurate, because if you're not accurate, then when delta is calculated and takes you to your lesioning temperature, your lesioning temperature is not going to be accurate. And so you're either going to be under or over, which means you could either be causing damage to surrounding structures that you don't want to, or you could be under treating your lesion. So having an accurate body temperature and probe temperature to begin the case are really important. Pre-op steroids, this causes swelling, no doubt about it, right? There's just no way around that. You're not taking the lesion out in 99% of cases, so you want to be able to kind of set yourself up to absorb that swelling, so to speak. I would hit them with tenodecadron intraoperatively before you begin the procedure, and then I'd start at 4Q6 postoperatively. If I do a 4-day taper on my craniotomies, I tend to do closer to an 8-day taper on my laser cases, just because there's going to be some real swelling postoperatively. Paralysis, the software has a trigger, and if you are kind of ramping up to get ready to burn and something moves, the laser has an automatic shutdown. If it detects motion, it's a safety switch, a safety trigger, not surprisingly. The way most of the times that there's movement, it's because the patient's not fully paralyzed. So make sure you talk to your anesthesia team about needing paralysis. I'm sure Monteris won't want me to say this too openly, but there's also ways to turn off that movement trigger, so you can do that if it becomes a constant issue. And you would talk to the person that's assisting you in the case. Post-ablation mannitol. So I don't give mannitol pre-trajectory and pre-laser placement because that may shift the brain and, of course, make your trajectory less accurate. But once you've actually done the burn, you know there's going to be swelling. So right after we complete our burn, that's when we actually instruct anesthesia to go ahead and administer mannitol. I do it weight-based. Whatever is your practice is, I'm sure, fine. If you never give mannitol, that may be okay. For larger burns, I would advise in favor of it. So these are the things I think that in general are worthwhile to think about. It's a little bit different than a craniotomy in this perspective. It's important to kind of get your anesthesia team used to these slight differences.
Dr. Fecci, so we had one question texted in, and Dr. Neimat actually did address it, but do you automatically request an arterial line for every case or on a case-by-case basis? We've migrated to no arterial line for healthy patients with small lesions often.
Yeah, I think that's going to depend on your anesthesia team and their comfort level. We're hard pressed in the neurosurgery world at Duke to not have an A-line placed in a neurosurgery patient. As we become more and more comfortable, we are scaling back on a variety of things. I don't think it's untoward to not bother with an A-line in these cases, frankly. I haven't broached that with my anesthesia team yet. There's been other things that I've tried to scale back first. But I think it's not automatic, and I think you can use your best judgment for things like Joe said, size of lesion, et cetera. And I don't think it's unreasonable to not scale up. I would say that this is a bit of a longer case, and there can be snafus that make it longer. I would highly recommend Foley placement, no matter what.
One comment I would make: if you're using a diagnostic magnet, I think heating the patient is key, because you're going to have, you can really only heat the patient with with the bear hugger in the OR. Then you have this long trip down to a diagnostic magnet, which in our case is sort of 2 floors down. That becomes a time when they really can get cold. And I've had a couple cases where the patient came in the room and they were 35 degrees, and that probably doubled our ablation time. I mean, it really can make a difference to get, if you're having to get the patient up from a lower core temperature. So it's something more important to consider.
Yeah, it's liable to limit the size of the ablation you can get too, potentially.
Yeah, absolutely. As far as A-line, I do think, I mean, we do a lot of DBS stereotaxis. We don't put an A-line in all of those patients. I do, when I insert the probes, want to know that the patient has a systolic 140 or less. As long as there's not a significant concern with the patient being hypertensive, I haven't pressed for an A-line, but it's certainly not unreasonable to have one, and it's.
Yeah, the only thing I would say there's a caveat is keep in mind that these patients are going to be in the scanner for a while, and you probably don't want the blood pressure cuff inflating. So, if you're concerned about the patient, the A-line's a kind of non-motion artifact way to continue to get vitals. So I think you just have to use your best judgment. I think the key thing that I try to ingrain upon my residents here is that it's not the same as craniotomy. Most of the time in craniotomy, you're taught in the tumor world kind of have your tumor at the top of your field. And that's just not as necessary here. In the sense, it's very similar to like a stereotactic biopsy. You can drill right into the lesion this way. You don't have to drill straight down. And in fact, the most important thing for positioning in these cases is that the cables are going to come out of the head at an angle. If you look at the bottom right picture here, you can see that the cables are kind of coming at, maybe a 35-degree angle or so. I don't know. But the point is, if they're coming straight up out of the patient's head, they have to make a 90-degree turn into the bore of the magnet when you roll the magnet over the patient. And that becomes an issue because if they're really contacting the bore, particularly if you've got a thin bore or a small bore magnet, your magnet's not going to allow that. You're not going to be able to get that scanner over the patient and conduct the surgery. So the idea is to position the head in such a way that you really minimize the angle with which these cables conduct themselves into the bore of the magnet to obviate that problem. Another couple of things, like a lot of times you're used to seeing like maybe like a posterior temporal or posterior parietal lesion and thinking automatically that you should go lateral. It's just not the case. I mean, in general, because you're going to be rolling that patient into a scanner, lateral is almost never the preferred position. So you're almost exclusively going to be supine or prone. So if it's very far back here, you're either going to be supine with a head turn and having it come out this way, or depending on where it is, like how far to posterior midline, you may want to consider prone. But lateral is almost never going to be the right answer here. There are some other issues. So if you look at this picture here, so both of these two pictures are from my OR. And I think, I'll just say a couple of things about this. So what you can see here is the atama. And so you can see how the head is positioned here. This is obviously someone who's had a prior cranie. I don't see where their bolt is, but again, the idea here is that this looks like wherever the lesion is, the cables are going to be coming straight back towards the magnet. Use your hula hoop to make sure that everything fits appropriately in the scanner. And then kind of coming to my images on the right here from my OR, what you'll notice, particularly on this top right image, is that it looks like a 1970 Chevy with like rear quarter panels that are different colors. And this is really MacGyver to get that patient into the scanner properly. So what you have to do is the bottom coil, just like when you do intra-op MRI cases, is underneath the patient's head. The top coil you really want to position in a way so that you can get the head kind of between the two coils, or at least the region of interest. We do not have wireless coils. We're just not lucky that way. So if you do, fantastic. If you don't, you have to be able to get this to rest in a way that allows the two coils to have the lesion in between. And also doesn't rest on the driver and the cables in such a way that creates an issue for you. So this actually is one of the more complicated parts of the case at times. And what we generally do is sometimes we prop it up on green towels, which are actually under the coil in this top case. Or you can actually slide the coil down to kind of push against the driver a little bit. It won't disturb things, as you can see in this bottom picture here. And then once we have the coil over our drapes, which are sterile, and we have the coil wrapped in a sterile turkey bag so that it's also sterile and contacting the drapes, what we do is we actually use IABAN to tape it down in place. This is one of 1,000 different ways you can jury rig this, but the key point is that you actually have to think about it. And for the first 4 or 5 cases you do, this may be a pain in your butt until you get a system that works out for you. So anyway, so just think about how you're going to MacGyver this to work. It is a bit of an issue. And the last thing is posterior fossa lesions. So if you can imagine, if you look at this bottom right picture, this is a patient that's either supine or prone, doesn't really matter. But the fact is that the coil and the cables go out towards the coil of the magnet that'll roll over the patient. If you can imagine having a posterior fossa lesion and you have to drill up because of the angle of the tent potentially, that means that the cables are going to come out this way and have to make closer to a 180-degree turn to go into the bore of the magnet. That can be challenging. Most of the cases I've done in the posterior fossa have really been cases where I could approach from a retrosigmoid position. And if you think about that, if somebody's face down and you're retrosigmoid, you can kind of potentially be angling a little bit more out and around than downwards and then back upwards. And so I think for lesions that you can approach from a retrosigmoid angle and that aren't so deep that you're worried about brainstem compression or fourth ventricular compression if you burn them, I think those cases are approachable, but you should gain a lot of experience with this procedure before you start going marching into the posterior fossa, I would say. On the left, what you're seeing here, if you're someone who's trained on an intraoperative magnet and you're used to IMRIS, this is the IMRIS head fixation device. Obviously this is the adapter here down at the bottom that fits into the bed. The key thing here that I want to drive home is that you really need to position your patient before you put the pins in a way that is exactly perpendicular to kind of where the pins are going to go, or for the most part, because these IMRIS systems, you have no ability to take the central bore of that Mayfield, for lack of a better term, where it connects to the adapter. It can't be up here. It can't be up here. It has to be dead center. So you've got to position your patient in a way that when you just come straight in like this with your pins, that's going to work for you. And just keep that in mind. There's really not a lot of wiggle room. Otherwise, you won't be able to hook your adapter up to your actual head fixation device. That's it. Many of you have done IMRI cases or are already familiar with that. If not, and this is going to be your first time dealing with that, just make sure you're keeping that in the back of your head.
I think it is a very clever device. I mean, part of the challenges that you have, particularly with the diagnostic magnet, is that you're doing everything upstairs. You have all of this spaghetti coming off the patient, and you have to get the patient transferred. So something I really like about the Atama board is that it sits on your OR table, and it essentially keeps everything with the patient, and you can just pick it up, and it has nice handles, and you can just take the patient with you. That's coupled with what is essentially a sort of a MRI compatible CRW type head frame, and that works exceptionally well. It's bolts that go into the head. They will keep the head still. You can rotate it nicely, and you can do that even as you're positioning the patient. So it's relatively, it makes the procedure relatively easy. The reasons I don't use it are just I think a limitation of our magnet, not because I don't think it's a good idea. It works quite well, but I do think it's important, even if you're not using the Atama system. What I typically use is a slide board with some egg crate on it, which is thinner and easier. And even though I'm not fixing the head, I do want to have that patient kind of all wrapped up in the OR so that I don't have to shuffle a lot of the wires and things as I get downstairs.
One thing I'll say is that the accuracy of your trajectory is really important here. So for me, almost exclusively now, when I register with an Aero CT, and then I just fuse that CT onto the preoperative MRI, and then I can be relatively assured that I have a very, very detailed and accurate trajectory. Now, you may not have that luxury, of course, but whatever you feel is the most accurate way of forming a trajectory, that's what I would go with. I would argue that skin fiducials are potentially the least accurate way of doing anything navigation-wise, and I would avoid those at all costs. Bone fiducials and StarFix, I'll let Dr. Neimat talk a little bit more about that, but that would be a potentially decent use of bone fiducials, which are obviously quite accurate, but you've got to have a good reason to want to drill fiducials or screw fiducials into someone's head, and there can be good reasons in the case of StarFix or some similar devices, so I'll let him touch upon that. We will talk on the various stereotaxy systems that exist on the next slide, so I won't talk about that here. I think that one question you'll have to ask yourself as you do this procedure is, are you planning to biopsy? Certainly in epilepsy, you may not. In tumors, I would advocate strongly for it. It's going to allow appropriate treatment of whatever it is you're diagnosing, and if it's progressive disease versus radiation necrosis, for instance. If it's progressive disease, you are going to want to deliver further radiation after this. And then the bolt placement is simply through, if you're used to variguide, it's simply through the black ring of the variguide. The T-handle screwdriver goes through the ring, you put the bolt on the other side, you tighten your ring a little bit, and then you're able to screw the bolt right into place. If you're going to do multiple trajectories, i.e. you have a lesion, let's say 4 centimeters, and so you need to drop 2 lasers down in to cover that, which shouldn't be the majority of your cases, FYI. But if that's what you're going to do, the most efficient way of doing that is to, while you're sitting there with your variguide or Vertec or whatever you've got, is to drop your first bolt, choose your second trajectory that you planned in your navigation software, drop your second bolt, and then you'll roll the scanner out or go to scanner, because you can put the laser down the first trajectory, scan, see where it is, do your burn, and then while you're in the scanner, just simply take that laser out and place it down the second bolt, scan, see where the laser is, and burn again. You don't want to have to go out after your first treatment, get a new trajectory, place another bolt. That doesn't make any sense. So however many bolts you're going to place them all up front all at once, get your biopsies if you're going to do them, and then roll the scanner after that.
Yeah, I mean, I think that covers it well. I mean, I think when it comes to your choice of stereotaxis, it really, in my mind, is dependent on 2 things. One, how big is the lesion that you're trying to treat? And 2, how far away is that lesion? If you have a very small lesion and a long distance to pass, it becomes important, I think, to have greater accuracy. In my mind, things that are rigidly attached to the head typically produce that greater accuracy, and that's been demonstrated in a number of studies. When you compare those systems, and we see a bunch of them here, they're pretty much all the same. They are, on the order on a Phantom of, a ½ millimeter accurate, whether it's a Lexel frame or a Starfix or a Renishaw, Rosa robot, etc. A little bit less than that is something that is not rigidly affixed, like the navigation arms that you see. But for most things, I think, if you're not going for a very long pass or a very small lesion, the accuracy of those is more than adequate. In my workflow, you typically get 1 pass at this. So something that is, the Monteris bolt makes this very easy. You do your stereotaxis, you put the bolt in, and that stereotactic trajectory is fixed, whether you're putting the laser in right then or downstairs. But you can't easily change it, particularly if you're downstairs in MRI. You won't have, if you're off, you won't have another opportunity to readjust, to make a small deviation and get it right the second time. So for that reason, we've gone to the Starfix frame, which we know to be very accurate and reliable. And I'm happy to answer questions about any of these. I've either used or seen all of them used. I think I've pretty much used all of these in one point or another. So happy to discuss any one if people have specific questions.
So, and I think, Dr. Neimat, he alluded to this. Really, like, once your bolt is placed, you're committed. And so, if you get in there and your trajectory's been off, and you need a second trajectory to cover the lesion, it's a pain in the butt. So if your lesion is kind of on the border where it's 3.5 centimeters, let's say, or 3.2 or 3.3 centimeters, and you're going to be going to a diagnostic scanner, those are cases where you may want to have the backup of a second trajectory, because if you're relying on your trajectory to be perfect, that's where I think registration techniques like the arrow are really helpful. Facial recognition and certainly skin fiducials are going to leave you with some wiggle room that you don't necessarily want. There are some other ways that you can kind of help yourself trajectory-wise. First off, the best you can, it would be nice to choose an entry point as long as anatomy permits to be somewhat perpendicular to the skull. So if you're going to have to skive through the skull, the steeper the angle that you're driving through the skull, the less accurate your trajectory is eventually going to be, even with a non-skiving bit, because those non-skiving bits, the tip of the drill still have to catch the bone. And so you're going to be drilling through the ring if it's an arm, like the variguide that you're seeing in the picture on the top here. I definitely would recommend using a non-skiving bit. If you have a drill stop and it's got a little cuff and there's a screw, make sure the screw is at the top of the cuff, because if you've ever drilled with the screw on the bottom of the cuff, as you go down the variguide, you'll notice that it eventually will hit the back of like joint 3 there, right? So just, it's a terrible design. Just think about these things. I mean, they seem simple, but they're important. I also like having a drill guide that our group has machined that docks down on the skull, just because it avoids trauma to the tissue as you drill. If you're drilling slowly, and I can speak to this from an unfortunate experience, if you're drilling slowly and you've got a dull drill bit, keep in mind that any drill guide that you've got that's up against your tissue is probably getting hot from friction and can burn the patient. Think about these things. These are the things that will eventually plague you if you don't think about them. So again, maximize perpendicularity. I'm not sure it's a word, so I put it in quotes, but that's essentially what you want to do, is make sure you're coming less skiving through the skull if you can. Another key thing, it's really important, once you get through with your drill, what I do is I take my drill bit out, and of course you've got a drill stop that tells you the length in general from the bottom of the drill stop to the tip of the drill is your length through bone. So in theory, that's your length to dura as well. So take one of these little dural punches, these kind of long awl-like devices, measure it out against your drill bit from the bottom of your drill stop to the tip of your drill bit and mark it, and then put that down your variguide or similar until that mark will show you when you should be hitting dura. Punch through the dura, make sure that you're all the way through, do it a couple of times, because first off, if you're not through bone, you're really in trouble, and this will allow you to go back and drill. And if you're not through dura, your laser catheter can get caught on there. It can alter, if the dura is not punched, it can alter the trajectory. The dura is strong enough to deflect your trajectory when that laser probe goes down, of course, or even your biopsy needle for that matter. And the dura also can catch it, so that if you try to pull it out, there have been cases where people have snapped the laser. You don't want that to happen. So make sure that you have nice, good clearance through the dura. Assess your clearance to skull. We talked about that. Insert your biopsy needle or mandrel to your target. So this gets into kind of puncturing your target. If you think it's going to be firm, make sure you're into it. There was this question. Now, actually, we're going to get to that still later, so I'll wait on the biopsy portion of it. When you get that bolt and you're going to go through the bone with it, we say 16 half turns or 8 full turns with the T-handle. If you have a shallow lesion, less than that is sufficient. We talked about the notion that if you have multiple targets, it's best to place all your bolts up front. And in general, you want 11 millimeters between those bolts to allow appropriate clearance. And then when you're done and you've taken your biopsies or whatever else, you've taken down whatever your stereotactic device is, and all you've got left is the bolt. What you want to do at that point, actually before you take down your stereotactic device, you want to take your brain lab stick or what have you and touch the tip of it just to the very lip of the bolt. That's going to give a distance to target that the Monteris folks are going to use to calculate depth probe, the probe depth.
I mean, I would comment, it's always important to know what you are measuring from. So as you describe here, the CRW and the Lexel frame have different radiuses to their target. We have 160 and 190 respectively. The same is true. There's a distance from the Starfix frame to target, which is written on the frame itself, and it varies depending on how you plan the frame. What I like to do is I actually like to measure it 2 ways. I measure it sort of from the frame to the top of the bolt, and then I also do a calculation where I know from my plan what the distance was from target to the outer table of the bone, and then when I insert my bolt, I know that is a 42 millimeter bolt minus the 6 or so millimeters that I've screwed it into the bone. So I essentially add 36 from that original distance that I measured from target to outer table. Those 2 measurements should agree, the measurement from the frame and the measurement sort of from the target. So I find that useful just to double check. If there's a great disparity, then somewhere I've missed a calculation.
This is a point of contention, maybe a strong word, debate, let's say, within the field. A lot of people don't do biopsies when they do lit on the tumor side of things. I can tell you that we have done retrospective studies. We're about to do a prospective trial. Our retrospective studies are very clear. If your biopsy reveals tumor, i.e., and most of what I do is recurrent Mets, recurrent GBMs, radiation necrosis, so most of these are radiographically progressing tumors where you kind of want to know. It's important. First off, biopsy permits information that does more than just allow you to know what you're lydding. And these are multi-D type discussions. If you get a biopsy that says recurrent tumor, even if it's recurrent metastatic disease, repeat SRS is the correct answer, and there's no doubt about it. Repeat SRS plus lit is more effective than either alone for a recurrent metastatic disease, and it's quite additive, frankly. And if it's radiation necrosis, then you know that your procedure may be essentially quote-unquote curative. Also, if you're looking at recurrent tumor, a lot of times a good example would be a breast met. Various breast mets into the brain may have different hormonal status than the primaries, and these things may impact treatment decisions that your medical oncologist is going to make, et cetera. So it is really, I think, important, whether you think you know it's recurrent disease or not, to get that biopsy and to have that information available to your oncologist or whomever. It can be done very efficiently. I mean, I think you want to wait for your biopsy result to at least confirm that you're intralesional. You don't necessarily need a diagnosis. But what I often do is I'll do my biopsy down the variguide, let's say. I'll send the specimen off, and then while they're looking at the specimen, we'll go ahead and screw the bolt into place. Just something to kind of maximize efficiency. And if it comes back that you're not intralesional, maybe you're too shallow, too deep, what have you, you can always biopsy down the bolt. So you haven't really lost anything, frankly. The biopsy, and this does address the question that I think Carrie asked earlier, which is a really good question because it's a very key point, honestly. The more biopsies you take, the more space you create in that lesion, air artifact, what have you, the more artifact you're going to create for your for the thermal ablation when you're trying to see how your field looks. And so you don't want to take 6 specimens. In an ideal world, you take one. Your frozen would confirm you're intralesional. You'd rotate, take a permanent, and be done with it. What I also would recommend is when you set your target, and this is a key point, when you tell Monteris what your target's going to be, they're using that to determine the deepest point to which the laser can be placed. And so oftentimes when you set your trajectory in IE Brain Lab, you're taking your target to a pretty deep point of the lesion because you want to make sure that your laser can go deep enough to get cover the entire lesion. That same depth that's at the deepest point of the lesion, I do not use that depth for my biopsy target. I set my biopsy depth quite a bit more shallow for all the reasons that Carrie is alluding to. When that biopsy needle comes into the lesion, I may want to get some, kind of just into the lesion where I'm getting potentially some enhancing component and potentially a necrotic component, but I don't want to go all the way through the lesion to the deepest point that I've told Monteris about, because now you've created air throughout the lesion. And that is problematic for 2 reasons. Number 1, artifact. Number 2 is that when you go and place that laser catheter down your biopsy tract and you roll your scanner over and you get a pre-op scan or pre-burn scan to see where your catheter is, that biopsy tract makes it a little bit more difficult until Monteris finally, after years of asking, goes ahead and puts a radiographically opaque marker at the tip of the laser catheter. You can't really see where the tip of your laser catheter is in that biopsy tract, and it's harder to start where you think you are in the lesion or set that as your initial depth. So there's a variety of reasons, I think, to set your biopsy depth as shallow as you feel comfortable doing it, but at the same point giving Monteris the deepest point in the lesion so that you don't end up with a laser that can't pass to the depths of the lesion. So anyway, that's it. And then the other thing is you don't want to take a lot of passes because if it bleeds, which I think Keith is going to show you here, this is from one of my cases. This was a GBM kind of in the internal capsule area. If you get a bleed from the biopsy, which we did in this case, you can see what impact it has on your mask. And this is the artifact that's been created. You can't see what you're doing. You're waiting to have to see the heat come out to the other side of that artifact and into the lesion. That's really not an optimal way to be burning a lesion. This is the only case I did where I had to combat this, and it certainly altered my capacity to treat. So, in any event, just be cognizant that if you cause a bleed, it's going to make your ablation very difficult.
So I have always done my procedures in a diagnostic magnet. I think there are some key points. So I do think it is very useful to have when you start the case, whatever board you are going to carry the patient on should already be in place, unless you have to, drag the patient from one bed to another with roller things or pull sheets or what have you. You're just better off. There's less likelihood that something is going to get snagged or pulled out. Because again, we have a magnet that is not used to doing procedures, we try to do as much as we can upstairs. So my tendency is to put although I've done it both ways, I will insert the mandrel and then insert the laser probe upstairs, and just sort of sit the robotic driver and all the wires coming down on the patient's chest, keeping them clear of anything that would snag on it. We put a purse string suture upstairs, so we throw a monocryl around the bolt at the beginning, so that when we're downstairs, at the end of the case, all we have to do is remove the bolt and tighten that suture, and you're pretty much done. There's no real sterile procedure downstairs, or a need for a full sterile field. There is, if you are traveling without the MRI in place and you're planning to put it downstairs, there is a plug that you can put in the back of the bolt, so that you can prevent CSF leakage. It also sort of helps to cover that bolt so that you maintain a sterile field within it. I've often put some tegaderms around it. I have a partner that will sort of leave a sterile field in place and put a sterile X-ray bag over the patient's head. I don't do that, but that is something that some people will do. I think that's not unreasonable. This last point, I think, of having a team downstairs in MRI that knows what you're doing, this is just critical, because it really is. This is an unusual case. You are doing a treatment downstairs. Most MRI teams are not used to dealing with that, and so the guys that I work with have been a tremendous help. They are very familiar with this. They are comfortable with it. And they've really made it very easy. So it's important, I think, to have that kind of engagement. If you're doing this, one point that's important: the first time you are doing this in a new hospital, if you are in a hospital that has not done this before, spending some time before your first procedure to meet with your MRI team, to talk to your anesthesiologists. There are some oddities. Once you get it down, it's not difficult, but there are some oddities of this case, the transport, the MRI procedure, that are important. Just something as simple as actually looking at your coil and seeing what kind of coils they have available to you and which ones you'll be able to use. If they don't have a flex coil, had to get one eventually when I came to University of Louisville. Before that, we were using these big birdcage coils, and those are more complicated and more difficult to use. And so being ready for that ahead of time prevents a lot of sort of audible calling and MacGyvering on the day of surgery.
I think the biggest thing is that when you actually set up your case here, you'll notice that these guys have fixed this whole device that holds the robotic driver onto the operative bed. So this is obviously, if you're in an intraoperative MRI, you're going to be on that bed the whole time. You're not going to be moving to another bed. And so that means that when you set your patient up immobilized in the head holder, we talked about needing to center that IMRIS head holder device so that it's essentially perpendicular to the skull before you close it. And you want it kind of centered in the bed as well. Obviously, when you hula hoop, you're going to want to make sure that you're going to be fine in the bore of the magnet. But you also want to make sure that the adapter and the head holder and all these things don't block the two holes on the bed that this device is going to slide into. And you can do that if you're not careful. This is a good picture of it there. So just be careful that you haven't blocked those two holes. This is skull with bolt already in place, so we'll skip to that part. So the first step in general in this point, when you have your bolt placed, is that you're going to fix your robotic driver to that bolt. So everyone has one of these in their living room, right? Okay, perfect. So all you need to do is, there's a couple of things. So first off, there is a little rectangular piece here. In general, this is going to point towards the nose of the patient. So you want to slide this down. You'll feel it kind of get to a stop point. This orientation towards the nose is important to give them, for the side fire lasers, the information they need to kind of direct which way the laser is pointed at first. There's also other ways to do it with little fiducials, etc. But if you're not using one, this is kind of the standard way of doing it. Once you have that fixed in place, you're going to turn this little set screw on the side here. That tightens this down over the bolt. This is now I can pick the whole head up by this. This is fixed down on the bolt, no problem. So once that's done, and I said it's actually lucky I remember how to do this because I don't think I've had done this over a resident in like the last, I don't know, year. But basically what you want to do here is you're going to look at your laser catheter, and you'll have taken your stick and you have touched it to the lip of the bolt at some point and figured out your depth to target. And now with this new fancy yellow laser ruler, you'll be able to just actually put that number in. So if you figure out that your depth to target is 95, for instance, then what you do is you're gonna actually adjust that. So there's a little yellow clicker button here on the back, and it's two sides. So you're gonna squeeze it between two fingers. You'll hear it click, and now I can move the laser in and out of the ruler. I can look at a depth in this particular laser length of 95. I won't be able to show you this, so I won't. You'll just have to take my word for it that it's at 95. And then I'm going to lock it into place by clicking these two buttons. Then you've got to get this ruler off because this isn't going to do you any good in the brain. So when you take a look at these little green buttons here, these are the release for that. You push these, and now I can pull that ruler off, and I'm just left with my laser. If the laser doesn't work, and of course Montero's products always work perfectly, so that won't be the case, but just in case, you can check with a little button here, a power source, and now the Montero's person will typically tell you to make sure that the laser is working, and this one obviously is, so you can feel pretty good that you can use this as a proper laser in the head. But it's always worthwhile to check. So now, at this point, you're ready to insert the laser into the head. And just as Keith was talking about, I don't know that you'll be able to appreciate this on my laser, but what you can see here, what you may not be able to see, is that there's essentially kind of an indentation here that is somewhat trapezoidal, and there's a wider, it's kind of long, and you can see it kind of up in here, but then it also has basically a wider point in one place and a narrower point in the other, and you can see on this that there's a corresponding piece here, this little trapezoidal rectangle around the laser probe entry point here, and this will fit over that kind of rectangular trapezoidal piece with a polarity that you have to match. So I'm going to look at it, and I can see that the way that this is going to work is this way. This is the only possible way it can go on. Now, the key is this, and this is really important. When you go to snap this on, you may have to push the green button again to get it over the cuff, but you may not have to. But as you put it down, this particular part of the robotic driver is going to be set to the correct depth for the laser, but it can be pushed with manual force. And if you push too hard getting this on, you will push this down, which means that you will exceed your desired target depth, and you can plunge the laser catheter through your lesion into some part of the brain you do not want. So this is really the most crucial part of this, is that as you snap this on, hold this with your other hand until you hear the click. I don't know if you could hear that audibly over the computer, but I could. So I know that that's in place now, and that's not going anywhere, and I made sure that I didn't plunge my laser deep into the lesion. Once you've done that, you're all set. It's ready to go, and the Montero's folks will have taken the other things from you. You'll have handed these off non-sterilely to them into their hands, and you're ready to ablate.
So after that first MRI scan is taken after probe placement, there's just some general steps that are done within the software workflow. So this first step up top, this shows image fusion. So if you have preoperative scans, you can bring in the intraoperative scan that you've taken after probe placement, and you can fuse that with image registration. And then you can move on to outlining the borders of your lesion if it's a tumor case. And then from there, you look for the artifact. So it should be a black line running through the brain into your target. And then this red and blue software rendered version of the probe is then superimposed directly over top of that artifact of the probe, so that that way everything in the software is lined up and it knows where the probe is positioned in the brain.
Pretty self-explanatory, but again, I think it is useful to outline the lesion. I sometimes do that even with the hippocampal ablations. It's not 100% necessary, but sometimes if you're coming at a very oblique angle, your view of the anatomy may not be the most obvious. You can toggle between trajectory views and anatomical views, but it is helpful to sort of know what you intended to ablate before, particularly I think with non-enhancing lesions, particularly with lesions that are not super obvious on MRI. It's useful to know what you intended at the beginning.
No, I agree. I think I like to outline the lesion. Do you have to do it? No. But if you're bringing the mask up and down, you may see your contrast less, but you'll always see the outline of the lesion. And it just kind of makes it mindless as you're burning, so that you don't have to be as worried, particularly if you do it well. And it adds just a few minutes to the case. I think that the biggest question here on the tumor side of things is you're going to give contrast in that pre-burn scan, because you obviously need to see that lesion if you're going to get an accurate burn on it. And so that starts to beg the question of, are you going to want to deliver further contrast after the burn? And if your institution is like mine, in general, the radiology teams don't like to deliver 2 full doses of contrast in a 24-hour period. So, and they're going to fight you on it. So if you really want to see how the contrast distributes post-burn, then you'll need to consider giving a half dose of contrast pre-burn and another half dose post-burn for your immediate post-burn scan. I don't find that so important to me. I tend to use FLAIR and GWI to get a good sense of what my burn looked like. So I just give my full contrast dose up front because I want to make sure that I have the lesion properly visualized so that I can get an accurate burn. That's more important to me. But that's very subjective. It's very individual. You can argue that I'm wrong. You can argue that I'm right, and no one will be able to tell you otherwise. But just be aware that that's a consideration you have to have. So if you guys look at the pictures on the right, particularly for those of you that don't have a lot of lit experience, what you'll see, can you guys see my cursor, by the way? Can someone just say you can? Yeah, okay. So there's 1 picture, 2 picture, 3 picture. These are the 3 slices, okay? And you have to realize that these are corresponding to the 3 slices you're seeing here in red, okay? So each of these red stripes is corresponding to a depth that you're looking at as you cook, and you can see them now perpendicular view here, okay? So the key point here is that as you are burning, you're going to be looking at those 3 depths simultaneously. And if you're using a full fire laser, when you set your depth of the laser in the target before you begin your first burn, if your lesion was this big, let's say, then you would probably want to bring the tip of your laser catheter to about the deepest point. So if you're looking back over here now, you're looking at a full fire, wanting to have that tip of the laser maybe around, in between the 2nd and 3rd line for this lesion or something of that nature. If you're dealing with a side fire laser, however, first off, your heat actually angles downward from your laser, from the kind of X marks the spot, and there is a little X on the laser, software generated laser. It'll look like this. You know that you're going to cover deeper than your laser is in the lesion. And so if I were going to try to get this lesion in 1 burn with a side fire laser, I might set that X basically right at the middle line here, and then know that I'm going to cover deeper and more superficial. So I think that's kind of the key point of this. I exclusively use the side fire, so I'm always thinking about the fact that I'm going to cover deeper than my laser tip. But I think, Joe, if you want to comment a little bit on your, when you set a side fire into the hippocampus, how you think about that. Sorry, full fire, I mean to say.
Yeah, I think, I guess the way I think of this is it depends a lot on what I'm ablating and what I'm concerned about. So I'm always wanting to see the planes with the either the area that I think I need to get, the anterior portion of the hippocampus, or structures that I'm worried about, the vessels in the ambient cistern, or something that I think I might be concerned about ablating. And so I will adjust. So you're able to adjust these red lines to 3 lines that are deep or 3 lines that are more shallow, and sort of pick your planes of interest. And so I will do that sort of on the fly. Typically at the front of the ablation, I want to know what my deepest ablation point is. So I will often use the deeper slices. As I work back, I get a sense of what I've already ablated and where I want to continue the ablation, and so I'll adjust my planes backward with that. Two other things to comment on. So one, when you're looking at ablations, you're looking at the blue line and the yellow line. The way I think of it, and I think this is pretty accurate and what I've seen post-operatively corresponds, anything outside of your yellow line is certainly safe. You don't have to worry about anything that is outside it. Anything that is inside your blue line, you can pretty much count on as being ablated by the laser. There is, if you compare them, and you can't see them both at once, but you can toggle between them, you'll see that there's a little space in between, the yellow line being a little broader and the blue line being a little bit more concise. In between, it is variable. You may have some of those areas that are at risk, but you may not have completely ablated that area between the blue and yellow. So it's useful to think of that as you're going back. And I will typically toggle between the two. I use blue line for things I really want to know that I've killed, and I use the yellow line when I'm getting close to something that I'm worried about and want to know that it's safe.
Yeah.
Last one is which probe. So for the hippocampus, usually because it is bounded by CSF space on either side, you're pretty safe with just the diffuse tip. I've occasionally used a directional tip in the hippocampus if I have a very curved hippocampus or I think it's going to be challenging in some way. I've usually reserved the directional laser for tumors and other weird things that I feel I'm going to need more control over.
Yeah, and like I said, I exclusively use the side fire or directional laser in my tumor cases, and that's all I do. And I think, the way I describe the difference between the yellow and blue line is kind of like a penumbra. It's this area that's at risk, and it may survive, it may not. So if you're super worried about something being eloquent, you may want to consider not going too much past the yellow line into that region. Yeah. So actually, this is a good example. You can see now in larger view here in this bottom left image, you can see where I've positioned the X on this laser. It's well shallow of the deepest part of the lesion. And it's a good bet, and you can see where the bottom red line here is at the bottom portion of the lesion. It's a good bet that you're going to cover at least to that depth with a side fire laser. It's also worthy to note that this is a pretty shallow lesion, and you don't see a lot of artifact here. So that's a good point to kind of remember, is that you really do get the ability to do superficial lesions with shallow bolt placement. And you can see that the directionality really does work. I mean, you can look at the arrow on the top left here. That's where the laser, now I've moved it, of course, just as I was about to say that. And now you'll see the heat come further out this direction where the arrow's pointed. I mean, it works. There's, anyone that, from competing technologies that tries to tell you the arrow doesn't work, that's just not true. It works just fine. And this is an area where I was pretty comfortable kind of going a little bit beyond my borders, but you can see that, I'm switching back and forth between yellow and blue line, and I'm making sure I've got good coverage. I might not be this aggressive if I was worried about a neighboring eloquent area. And that's, yeah, so there you go. You see yellow there, and you see blue coverage. Now this is probably artifactual dropout over here, but you can see good coverage of that lesion. Sure, so, the device removal is a piece of cake. You go in, you unscrew the bolts. If you've made a small incision, you're not going to get a Galeal stitch in. Don't bother trying. Just maybe I tend to run a monocryl, 2 or 3 stitches, baseball stitch, style stitch, kind of what you see in the hair here. That's about as much hair as I shave to, maybe a little bit more, just in case your skin moves when you're draping and your trajectory now suddenly lands you in the hair or something. I want an absorbable stitch because this way, this patient who's had a minimally invasive procedure doesn't need to come back and see me for like 2 suture removals in 2 weeks. They can just come back at the month. If you're going to a diagnostic scanner, I'll let Joe talk about what he does, like whether he puts a purse string around the bolt or not. Anyway, that's really it. I tend to get the next day, sometimes if someone's around, I'll get a contrasted scan. But if they're not, I just do my immediate post-operative DWI flare, and that's really it.
Yeah, I do pretty much the same, in the diagnostic scanner. I do a purse string. I typically, I open the skin with the drill. I don't actually make an incision, and so I almost always do just sort of a figure eight, and that's sufficient to close it. I've never had problems with that closing or healing, and then you're right. You don't need to have them come back for for suture removal. I think makes a lot of sense. As far as the imaging, I do, these are the same ones I get. GRE will, you will see, even when you don't have a significant hemorrhage, you will see some little bit of blood along the track of your laser. And so be aware of it. Do not overreact to it. I think that, if you get a GRE sequence, that's just something to be, to anticipate.
These screenshots that we're getting, so how we're able to replay an ablation. So every 8 seconds, there's a new MRI measurement that comes in as we're doing the ablation. And each time that what the surgeon is seeing on the screen is captured by the software, and then you can take all of those images and put them into video creation software and create the replays that you just saw on video. You can also bring in your post ablation imaging, and you can superimpose the blue and yellow lines over top of that post-op lesion. And actually, this is the case we saw earlier, Dr. Neimat, where we brought in that contrast-enhanced T1 image at the end of the ablation, and then brought the blue line over top of it. So again, these treatment profiles are saved, and they're easy to get into and easily saved onto a USB stick at the end of the procedure. So Dr. Fecci, I don't know if you have any other comments on this.
No, I rarely need to put a patient in the ICU unless I'm doing a deep tumor that I'm worried about, or unless they have some medical considerations I'm worried about. I'd say it's certainly less than 10% of my patients that see the inside of an ICU post-ablation. And actually during COVID times, when the pressure, of course, both from us and from the patients themselves is to get out, I've had an increasing number of people that I've discharged same day, particularly if they have a first case start, by afternoon, evening, if they're looking fine, I'll let them go. A lot of it in the tumor world depends on how close you are to an eloquent structure, how big the lesion is. Those things all impact all of those types of decision making. Like I said, I give mannitol after the ablation, so it doesn't affect my trajectory. Dexamethasone tapers a little bit longer than a cranie, I think, and I let the patient guide me. If the swelling's near an eloquent area, you may need to keep the steroids on for a bit. If they've been like a rad necrosis patient where they've been on steroids for weeks, you're going to have a little bit of a harder time getting them right off the steroids. You got to tailor it to the patient. It's not a one-size-fits-all type thing.
Yeah, pretty much the same. I will be a little bit more liberal to sometimes put the hippocampal ablations in the ICU just to watch them, but it's rarely been, I can't think of anyone who's really needed any special care. They all go home the next day. I put them on a 7-day taper of steroids. I don't routinely give mannitol unless I have a special concern. I haven't had to do that. Yeah, these go remarkably well. I do think these little videos that Keith talked about putting together are very useful. One, it's nice to see it afterward and to sort of see the progression of how the ablation was created. It's really nice to share this with your, referring epileptologist, referring neuro-oncologist. I think people don't really understand it until they see it here and actually see it in real time, or compressed time, how these things are done. It gives you a certain confidence in the therapy, and it's nice to share that.
Yeah, I agree. It's really a useful tool, teaching, just as kind of a record of the burn, all of that. And if you're ever going to do studies, it's the thing you kind of want to look at if you're looking retrospectively. So, and I'll add that I may be more aggressive in some ways that with the I'm at a point now where I rarely put my craniotomies in the ICU. So it's all kind of dealer's choice. It's got to be what you're used to, what you're comfortable with. The fact is that there's lots of ways to skin a cat here, but I think that the general consensus here is that this is a relatively well-tolerated, safe procedure, frankly.
So we do have a question. So for some of the deeper tumors with large ablation volumes, like hypothalamic hamartomas, we've seen significant edema 3 to 5 days post-op and have lengthened stay for that. Any other tips besides steroids?
Yeah, no, you're hitting the nail on the head here. I think you have to tailor it to the case, particularly a larger hypothalamic hamartoma. That's someone I would put in the ICU. The kid where I burned a thalamic lesion, that person's going to the ICU, right? So those are significant burns in areas that are near very deep, eloquent structures. So you've got to be worried about that. And really, as Joe's discussing too, with even the hippocampus, you're near the brainstem, right? So these are areas where if you swell, there's going to be significant consequences, and so you've got to tailor your care to that. I would not be. I've only done a couple hypothalamic hamartomas at this point, and I would not be in a rush to send them out of the hospital. I mean, I really practically needed new underwear after that first case, because it's scary. I mean, you're like, is this kid going to come out worse? Are they going to come out wrecked? Are they going to? It was a kid with gelastic seizures. They were seizing like 8 times a day. It terrified me. Are they gonna have like hypothalamic kind of storming type syndromes? Like you get after you're doing some of the nasty tumors in there. I was scared. I wouldn't be sending that person home same day. I think steroids is a great idea, of course. Depending on how things look immediately post ablation, if it's a bigger thing, I think mannitol is not a bad idea. Unfortunately, those are kind of your tools, right? Drive your sodium up a bit, get your sodium up to 140 plus. If you're worried about swelling, free water restrict the person. Anything you can do, keep the head elevated. All the magic maneuvers. But unfortunately, yeah, you're a little bit. Once you make your burn, you're kind of at the mercy of how they respond to it, and that's the scary part of it.
When this early on, when laser was being used, I talked to a lot of people who were doing pre-treatment with steroids. Is that something for large tumors that you've done or did routinely? I don't do that for the hippocampus, but I was curious about that.
A lot of the people are on steroids just because they tend to be preoperatively. I can't tell you, that there's a difference with pre-treatment versus not. I don't know. I've not studied it. There are papers in the literature from like way back when, decades ago, that insinuated that it was your preoperative or immediately preoperative steroid doses that were way more important than your postoperative doses. I can't prove that to you. I mean, I think if you're really worried, you're not going to hurt them. So it's probably not a bad idea to start early.
And what trajectory did you do? Were they pretty stereotypical for a hypothalamic hamartoma, or did you have a varied trajectory for the few that you did?
We came from, to be honest with you, not too far from Coker's, a little bit more anterior, if I recall, and kind of came basically down this way, and it gave us a nice route. It wasn't the biggest hamartoma in the world, so obviously if you had a larger lesion, you'd have to consider that. But those are, I mean, these are real deals. So what have you seen as far as, have you seen people come other routes?
I haven't done any hypothalamic hamartomas. I mean, we don't sit with the pediatric hospital much here, so I haven't seen any of those. That's why I was curious.
Yeah, we considered a temporal route as well. But I think it really depends on the size and eccentricity of your lesion. You got to look at a couple of trajectories and decide what the safest way in is. But you can certainly come kind of a little bit kind of, not quite, it's not subfrontal obviously, but it's a safe way in, or you may be able to access temporally depending on what's in your way and what it looks like. It worked great. The kid left on postoperative day 3 and was seizure free in 3 days. So the first.
Chima Alibo Children's National does those and uses a frontal approach always.
Yeah. Actually, one of my colleagues at Duke, who had trained at UCSF, had published a series of these and so I had him kind of consult for me when he does the epilepsy lit cases at Duke now, and that's Derek Southwell. And so he's got a paper out there that discusses a series of these of lit for hypothalamic hamartoma. You can look it up, and it's a good reference point, frankly. All right, guys, great to meet all of you. Great questions. Thanks for taking the time.
Thanks, everyone.
Thank you.
Thank you.